Good morning, ladies and gentlemen, dear colleague. The topic I am supposed to discuss today is biomarkers in diagnosis of acute kidney injury. Before we move on to the main topic, it is very important for you and me to know the burden of chronic kidney disease in our country today is quite huge. The SEEK study, which was a very well conducted study, across the length and breadth of the country put the burden of CKD as 17.2%. Some of you may be aware, under the auspices of Care for Your Kidney Foundation, we have done more than 10,000 screenings in the urban slums of Hyderabad over the last 5 years, and we found that the burden of CKD is close to 15% or so. The important thing is most of these people, like 8% in the SEEK study, only knew that they had chronic kidney disease. More than 90% are not aware. And they progress over a period of time to reach end stage. And the estimated number today is more than 2 lakh people who reach ESRD every year in our country. Imagine this huge number, out of which only 8,000 plus transplants are offered in the country. The majority of them remain on dialysis and continue to be on dialysis with a very poor quality of life. We all know diabetes, hypertension, stone disease, chronic interstitial nephritis, chronic glomerulonephritis contribute to the chunk of this CKD. But in the last decade or so, there is a clear understanding it is acute kidney injury which leads to CKD because of the progression of AKI to CKD. This is supposed to contribute to more than 30% of the total burden of CKD. This is data from 0 by 25 initiative of International Society of Nephrology, which puts in all the different causes for the AKI in low and middle income countries in the world. What is important is most of these insults, causes like dehydration, drugs are a repeated insults on the kidney. So you have now a clear understanding that recurrent acute kidney injury progressing to end stage kidney disease very fast. So those who have a episode of AKI seldom recover and become totally normal as far as their kidney function is concerned. They enter into a stage of AKD after 7 days of AKI, do not recover, and by 90 days they are categorized into chronic kidney disease. So the present understanding of AKI, AKD and CKD as a continuing spectrum today are important for us, and what you and I do to our patients when we see them in the hospital or in the ICU determines whether they fit into any one of these categories or eventually progress to ESRD fast. So the problem that we have today is that when you see a patient with acute kidney injury, the patient already has established most often more than stage 1 of AKI. Whereas we understand AKI syndromes have different injury mechanisms, different etiologies, and they require a personal approach if we have to prevent them to reach this end stage or CKD spectrum, and also to improve the outcomes vis-a-vis their morbidity and mortality. We do have a list of tests or markers which can pick up kidney injury, which will help us in the management of these patients. Let us go through a little more what we understand today. Every patient who has an AKI will enter into some form of a complication of AKI, whether it is a partial recovery of kidney function, ending up with CKD, ending up with cardiovascular disease, ending up with cerebrovascular disease. Risk of infections in this cohort is much more than general population. We also know that they have more fractures, liver disease and lung injury, apart from the fact that their mortality is much higher compared to general population even after couple of years after a single episode of acute kidney injury. So if we have to learn something about how to pick up very early, much before the AKI has entered stage 1 or stage 2, we have to take help of certain markers. By definition, a biomarker or a biological marker is an indicator of a biological state or condition that can be measured. So it should be able to evaluate a biological process or a pathogenic process or response to a therapeutic intervention. The aim of getting to know more about these biomarkers is to move towards the left of learning to pick up kidney disease earlier so that we can prevent downstream effects. The present markers that you and I routinely use every day, serum creatinine and urine output, have their own fallacies and they may not be as reliable to detect the kidney injury early in the phase of the illness. So we are aiming by learning these newer biomarkers, one, pick up at risk when the kidney is not yet fully entered into a stage of AKI. Also, when there is recovery, look at biomarkers which can predict the outcomes both in the short term and in the long term. If I have to enumerate, there are a list of more than 30 biomarkers that have been used in more than one patient cohorts and published literature. But our aim of knowing at least some of these biomarkers should be after an AKI insult, apart from the serum creatinine that we are looking at, we should be able to diagnose early, locate the injury, know the etiology of the injury. Also prognosticate what is the extent of injury, whether it is an ongoing injury or it has entered into an initiation of recovery. And later part of the illness to see the risk of future CKD or ESRD and also look at the mortality. As we know, AKI itself can predict all these things, so the biomarker should be able to help us in these decision making. The first ADQI which talked about biomarkers was in 2011 or so. Three papers which are very important. One published in Kidney International, current use of biomarkers in AKI. The other two published in Contributions to Nephrology, use of biomarkers to assess prognosis and guide management of patients with AKI, and implementation of novel biomarkers in the diagnosis, prognosis and management of AKI, shed a lot of light because they looked at varied data across the world and then came up with certain consensus statements. I had the privilege of being part of this mainly because of some work that we had done in NGAL in our cardiac patients. From India, there was another paper from Chennai which talked of 102 ICU patients, a single center study wherein they looked at the urinary NGAL at the time of admission, looking at the prediction of AKI subsequently and also mortality in the hospital. The two studies that I mentioned that we conducted was one in coronary angiogram group, and this was evaluation of serum and urinary NGAL as an early biomarker of AKI in patients undergoing coronary angiogram, percutaneous coronary intervention and CT angiogram. The second cohort was the biomarker in adult cardiac surgery. So we found that both the studies, the biomarker usage urinary NGAL was predictive of AKI 48 to 72 hours before the rise of serum creatinine, and in the cardiac surgery cohort they were also predictive of dialysis requirement when the patient went on dialysis even after 2 or 3 weeks after the surgery. To our surprise, in both the cohorts we found even before the insult, in the first study the angiogram, in the second study the surgery, some of these patients who had a low ejection fraction and who were on diuretics, the NGAL was already high, telling us that these group of patients were already at a higher risk of acute kidney injury because the damage marker was already elevated. So all over the world, lot of literature came in. The patent of NGAL was with Dr. Prasad Devarajan. He is an Indian in US, and they could do in multiple cohort of patients validation of NGAL as a good biomarker for acute kidney injury. So taking this as the background, if you look at our problem today, delayed intervention in AKI, because the present markers that we are using do not pick it up early, we are searching for something like a kidney troponin which will help us to pick up AKI early. We should be looking at a biomarker profile of either a urinary elaboration of this chemical or blood raise in the serum of this particular molecule. So when do we use it? We can use it to differential diagnose AKI which is established, and there are several in the literature which can help you with that, or diagnose very early AKI. Again, there are a couple of markers which are validated in this cohort, or prognosticate the severity and the outcomes, and again there are few which are useful in this field also. If you look at since 2006 till date, every year the number of original articles, original work in the renal biomarkers has been increasing, so much so in the last 5 years there are close to 400 articles which are talking about the role and clinical application of biomarkers in the diagnosis of acute kidney injury. Quickly to enumerate, cystatin C was one of the earliest markers which was found to be sensitive and detect decrease in GFR early in the so-called creatinine blind range. NGAL, I just mentioned to you, was tested or validated in various patient cohort, though the initial validation was done in cardiac surgery patients, subsequently in many others. Two cohorts where it is not useful is sepsis and malignancy cohorts. Kidney injury molecule is a molecule which is good and is upregulated after ischemia reperfusion injury, and it can have some amount of prognostic role also. Interleukin 18, originally described by Chirag Parikh and his group from Yale and subsequently was validated by the TRIBE consortium, is also a pro-inflammatory cytokine which can pick up ischemia reperfusion injury. Lot of publications which have gone in, and it has been validated in the cardiac surgery cohorts also. LFAB is not widely available, but it is available in Japan, and it is a renoprotective protein which is elaborated in AKI. Angiotensinogen could be a prognostic marker of AKI, and there is some data to validate it in critically ill AKI population. The sodium hydrogen exchanger isoform 3 is a robust marker of ischemic ATN. Finally, coming to the two cell cycle arrest biomarkers TIM2 and IGF-BP7, now used as a urinary product, are available in the world today. One of the biggest problems that you and I will face when we want to use it is the cost of these molecules, especially when we do not know exactly what value they bring to our bedside treatment of the patient. Urinary NGAL, many of us have used, costs anywhere between 6,000 to 7,000, and the turnaround time is the same day. And the NephroCheck, which we have used in 2 studies, again the turnaround time is not that good because it is still in the experimental stage in our country. We have to compare this as against serum creatinine, which is just 230 rupees in the hospital I practice, and the turnaround time is just 2 hours. So moving away from a established practice of using serum creatinine to a biomarker is not going to be easy for you and me, taking into consideration the turnaround time and the cost that it involves when you start using it routinely bedside. So we have to learn a little more about this urinary product of TIM2 and IGF-BP7, now known as NephroCheck and commercially available as NephroCheck. Discovery, Sapphire and Topaz studies validated this against many other available biomarkers and showed that this was the most robust of the lot with a cutoff point of 0.3. The first study we did with NephroCheck in our patient cohorts was done by Dr. Mahesh, who is known to all of you. We looked at AKI incidents in consecutive 150 cardiac surgery patients, and we measured the urinary nephrocheck 4 hours after the CT surgery. We followed up the patients for 7 days and then up to 90 days to look at the AKI incidence in 7 days and then CKD incidence in 90 days. It was not a very sensitive test in this cohort of consecutive patients, but it was quite specific, and we learned our lessons that when you use these biomarkers in all patients who undergo cardiac surgery or angiogram, it may not be a robust marker. You should use it in patients who are at risk. So you need to have another parameter wherein you can risk assess and then use the biomarker. Presently, we are part of a Biomarker trial that our group is conducting across 12 study sites in the country, wherein we are looking at biomarker enhanced management of acute kidney injury. Virinchi Hospital is one of the sites in Hyderabad, the other one being Star and Apollo hospitals, and across the country there are another 9 sites or so. We are looking at AKI risk prediction score using a Malhotra score, the minimum score being 0, maximum being 21. Anybody above 8 score is eligible for enrollment after screening. We are close to 50% enrollment completed in this particular study, and this is the design of the study. If anybody is interested, we can talk about it. We are going to look at whether the measurements of the NGAL looked at predicted AKI severity and also the long-term outcomes like CKD. So there were many papers, as I already mentioned. Urinary product of IGF-BP7 and TIM2, both inducers of G1 cell cycle arrest, were significantly superior to all the previously described biomarkers to predict AKI in several cohorts of patients. You can also do a AKI risk score using the same, and you can categorize patients into lower risk of developing AKI in the next 12 hours, moderate risk of developing AKI in the next 12 hours, and if the cutoff more than 2, highest risk of developing AKI in the next 12 hours. So will this be the ideal biomarker which is non-invasive, easily measured, inexpensive, which is not true? As I told you, the nephrocheck is going to be probably available as the Western countries around $100 per test, which may not be what we are looking for, but still it's a robust marker and we have to learn to use it whenever it becomes inexpensive in our country. So with this background, we should be able to pick up patients who have a acute kidney injury much before they have established stage 1 or stage 2 AKI. Once you have the biomarker available, you can categorize your patients into 4 categories. Patient with no functional change, that means the creatinine is fine, the urine output is fine, no damage change, that means the biomarker is not elevated. Second cohort of patients where damage marker is elevated, that means creatinine and urine output are normal, but the biomarker is high. Third category wherein creatinine and urine output are abnormal and biomarker is normal. Typically this will be cohort where you get a hypovolemia or pre-renal element wherein the function is decreased but there is no structural damage to the tissue. And the fourth cohort, the most important cohort to pick up early, where both the damage biomarker and the functional marker like urine output and serum creatinine are elevated. So when you have these combination with you, you can decide whether this patient has just a decreased glomerular filtration without damage to the tissue, like in a early hypovolemia or hepatorenal or nephrotic syndrome, or whether a patient is going into tissue damage wherein the damage marker is elevated. So your biomarker utility is going to be when you suspect AKI to pick it up early, when you diagnose AKI to differentiate whether AKI is there or not very early, to define the etiology and the lesion or the site and the cause, and of course once you are into established AKI, also to prognosticate. Many times when you look at the literature, you have a biomarker, you have a minimum value or a lab cutoff, and then you know a high value wherein clinically important. The in between area known as the gray zone, you are not sure what to do. I am raising this to tell you sometimes a serial measurement is extremely important rather than a single measurement. So once you have this information, you will categorize your patients into one of these four quadrants. But keep in mind, it is not like a airtight box. You will have patients moving from one quadrant to another quadrant as the patient is dynamic and there are changes happening in the patient's physiological milieu. So your plan is to look at the physiological phases of AKI. You take into consideration the clinical factors, physiological biomarkers, and also the biochemical biomarkers. Look at the patient or pick up the patient very early when he is at risk, when there is a functional change, when there is a damage change, and then look at these patients whether the damage is recovering or not, and whether there is a marker of recovery in these patients by the time that you discharge your patients. One specific cohort will be chronic kidney disease, wherein they are more prone for AKI, but your cutoffs of biomarker will be very different in this background. So you have to take into consideration a marker which tells you chronic kidney disease, and for the AKI the cutoff may be little different. So once you have all the information, KDIGO criteria or functional criteria for AKI, and along with that the damaged or biomarker criteria, you will be able to categorize your patients with biomarker positivity as mild, moderate or severe. There is data supporting once you use damaged biomarker along with the creatinine or urine output, you can categorize these patients and predict AKI onset, RRT initiation, in-hospital mortality and the composite outcomes also. So when you look at a biomarker, you are no longer searching for a kidney troponin. Kidney is not like the heart, it's more like the liver. Whatever background we have discussed now should tell us that these patients have an ongoing dynamic changes inside them, and you may have to look at a panel of biomarkers, some of them talking to you who is at risk, some of them talking to you early diagnosis of AKI, lesion where it is, and that is the location of AKI, extent of AKI, and also the etiology of AKI, and some of them talking to you about the outcomes or prognosis. So like the liver function test, you will have to use a panel of biomarkers with serial measurements to know exactly what is happening to the patient's kidney. I'm just quickly enumerating a couple of studies published. Privaki study was a single center study which looked at cell cycle arrest markers, that is nephrocheck, 4 hours after cardiac surgery. In the intervention group, they used the KDIGO bundle to prevent AKI after a biomarker became positive, and they found that though there was no difference in the secondary outcomes, there was a significant difference in the incidence of acute moderate to severe AKI. Privaki 2 study prevention of cardiac surgery associated AKI by implementing the KDIGO guidelines in high-risk patients identified by biomarkers was the same Privaki protocol which was in multi-centers, 12 centers in Europe, and though initially they screened 1,447 cardiac surgery patients, they eventually enrolled 280 patients into control group and intervention group, and found that in the intervention group, the incidence of AKI stage 1, 2, 3 was less, RRT was less, renal recovery was better, mortality and ICU stay also was marginally better. Concluding, implementation of a KDIGO derived management bundle was feasible in a multinational setting, and moderate to severe AKI was reduced in the intervention group. This was not cardiac surgery patients but other major surgeries. Big pack 125 postoperative patients who were biomarker positive randomized into bundle of care versus standard care non-blinded study. also found that in the intervention group, the incidence of any AKI and incidence of moderate to severe AKI was much less, statistically significant, leading to the length of stay in the ICU coming down and also significant cost savings. So this led to a lot of literature talking of preventing AKI using the new biomarkers and also following the KDIGO bundles. And there is some consensus evolving that when you use a test like NephroCheck, you can use cutoffs so that there is a significant reduction in the initiation of RRT when you do simple renoprotective actions based on the biomarker elevation. So this led to a consensus statement from the ADKI, which was 23rd ADKI, suggesting a combination of biomarkers assisting in planning of therapy and management of AKI. The recommendation received grade C. But you should keep in mind, and I am quoting from Osterman's article about integration of biomarkers into the diagnosis of AKI, clearly elucidating based on the data AKI can resolve, so you can move from one quadrant to another quadrant, sometimes improving, sometimes worsening. So looking at these markers at a different time point will help you to prognosticate the outcomes. So this is a study which was published in 2019 in Critical Care Medicine. 1,207 patients discharged alive from ICU. Patients with elevated kidney biomarker results, many of them, including proencephalin, at ICU discharge had worse one-year outcomes, though their serum creatinines were much lower. So the biomarker elevation predicted the outcomes at 1 year and not the serum creatinine at discharge. But there are limitations of these new biomarkers. I always told you, all through cost is a big issue for you and me. These biomarkers are available in some parts of the world, not available in some parts of the world. So whoever uses a particular one vouches for that particular biomarker. Sometimes uniformity may not be there. There are different cutoff values in the published reports. I already mentioned and brought in that gray area, which you should keep in mind when you are using it in your day-to-day practice. And though we know that renal insult is exactly known in certain cohorts like post-cardiac surgery or coronary angiogram, in a normal ICU patient, you do not have an exact time of insult. So it is not very clear, and you may have to do it at admission and then again during the course of the patient stay in the hospital. These are all later publications. I will not go into the details. This particular paper is BRAVA study or biomarker rule in or rule out in patients with acute diseases for validation of AKI in emergency department. This was published in 2022 and it talks of prediction of AKI development based on three parameters, what is known as a emergency department score, EGFR and NephroCheck, that is the cell cycle biomarker, which NephroCheck scored the highest statistical significance. Prediction of 90-day mortality based on three parameters, again the emergency department score, EGFR and NephroCheck. NephroCheck scoring the highest validity in this study too. Predicting AKI progression or AKI progression with death in sepsis. This study used a combination of NephroCheck with urinary KIM and combination of NephroCheck with urinary interleukin 18 and found that there was a significant improvement in the prediction when you use the biomarkers together. This is a particular study in abdominal aorta surgical patients in Japan, again looking at the multiple biomarkers predicting the outcome. This is much recent prediction of AKI in SARS pneumonia, wherein again they used 4 to 5 different biomarkers and found that there was excellent prediction of AKI in patients with severe pneumonia based on these biomarker levels quite early. So to conclude, AKI biomarkers can diagnose AKI much earlier than our conventional urine output and serum creatinine. AKI biomarkers have potential to reduce the risk of moderate to severe AKI in high-risk patients, as we saw from the data in different settings. Cost is a concern in our setting, and we have to gain enough experience to use them in our day-to-day practice. Leading to the consensus recommendation from 2030 ADCI, a combination of damage and functional biomarkers along with clinical information be used to improve the diagnostic accuracy of AKI, to recognize the different pathophysiological processes, to discriminate the AKI etiology, and to assess the AKI severity. Thank you very much, and I hope I could throw some light on our present understanding of AKI as we know today.